Hi. In this video, we will go step by step through the bones of the upper limb. We'll start with the shoulder girdle, or cingulum membri superioris. The two main structures here are the clavicle and the scapula. Then we'll move on to the free part of the upper limb, the pars libera membri superioris, where we'll look at the humerus, radius, and ulna. Finally, we'll review the bones of the hand, so that we can see the complete picture from the shoulder girdle all the way to the fingers. Among the bones of the upper limb, let's first look at the clavicle. We will walk through the 3D model, focusing on the important surfaces and attachments. Let's start with the lateral end, the extremitas acromialis. This is the flatter, more delicate side of the clavicle, which curves slightly backward in space and articulates with the acromion of the scapula. Next, let's move toward the corpus claviculi, the shaft of the bone. The clavicle is S-shaped. The medial 2/3 are convex anteriorly, while the lateral third is concave anteriorly. On the superior surface, the facies superior, the bone is usually smooth, with hardly any structures visible. The characteristic impressions are found mainly on the inferior side. Now let's look at the medial end, the extremitas sternalis. This end is thicker and bulges forward. Here we find the articular surface for the sternum, the facies articularis sternalis, which is part of the sternoclavicular joint. Among the longitudinal borders, let's first take the anterior border, the margo anterior claviculi. Medially it is fuller and convex forward, laterally it is slimmer and tends to be concave forward. Turning the bone, the inferior surface, the facies inferior claviculi, is the working side, where the attachment structures are aligned. The posterior border, the margo posterior, outlines the opposite curve of the S-shape. Above again, the facies superior remains smooth, serving as a good landmark. Returning to the lateral end, here we find the facies articularis acromialis, which articulates with the acromion. On the inferior posterior part we can palpate the conoid tubercle, and more anteriorly and laterally runs the rough trapezoid line. These two features serve as the attachment of the coracoclavicular ligament's two parts, the conoid and trapezoid portions, which connect from the coracoid process of the scapula. In the middle of the inferior surface of the shaft runs a longitudinal groove, the sulcus musculi subclavii, the impression for the origin and insertion of the subclavius muscle. Medially, also on the inferior side, there is a rough, fingertip-sized impression, the impressio ligamenti costoclavicularis. This is where the costoclavicular ligament attaches, anchoring the clavicle securely to the upper part of the thorax at the first rib. Returning to the medial end again, here we again see the facies articularis sternalis, connecting the clavicle to the sternum. And finally, at the lateral inferior part, once more the linea trapezoidea, working together with the conoid tubercle, it suspends and reinforces the shoulder girdle. Orientation summary: the subclavius groove always runs on the inferior side. The medial end is thicker and bulges forward, while the lateral end is flatter and bulges backward. The conoid tubercle and trapezoid line are visible on the inferolateral region, and the costoclavicular impression lies medially on the underside. Based on these landmarks, you can confidently position and present the clavicle. Clinical note: the clavicle is frequently fractured, typically due to a fall on the outstretched arm or shoulder, most often at the junction of the middle and lateral third. During healing, the callus may rarely grow into the branches of the supraclavicular nerves, causing persistent pain in the ipsilateral side of the neck. Among the bones of the upper limb, we are now studying the scapula. First, we will clarify its position, then we will go through the important structures on the 3D model. The scapula is a flat, triangular bone on the posterior wall of the thorax. At rest, it lies over the 2nd to the 7th ribs, approximately 3 cm lateral to the midline of the spine. Its medial border is nearly vertical, rising slightly obliquely toward the superior angle, while the inferior angle points sharply downward. It articulates only with the clavicle and the humerus. Otherwise, its position is maintained by surrounding muscles. Let's begin with the acromion. This is the continuation of the scapular spine, a flat projection that extends laterally and anteriorly. Its superior arch curves above the glenoid cavity, and its end articulates with the clavicle at the acromioclavicular joint. Next, let's move to the body of the scapula, the main plate of the bone. Here we distinguish the anterior and posterior surfaces, which we will show separately in a moment. On the superior part of the anterior surface, laterally, arises the coracoid process. It projects forward and slightly laterally, several muscles and ligaments attached to it, making it essential in suspending the shoulder girdle. Beneath the scapular notch, the program here refers to the glenoid pole of the shoulder joint. This area is formed by the glenoid cavity and its surroundings. The neck of the scapula is the narrow constriction of the articular portion, on which the head of the scapula rests. At its end we find the glenoid cavity. If we turn the scapula forward, we can see its anterior surface, the costal surface of the scapula. Here there is a single large depression, the subscapular fossa, containing strong bony ridges, the so-called muscular lines, which are shaped by the pulling force of the subscapularis muscle. At the tip of the triangular bone, the inferior angle is visible. It points downward and serves as an important landmark. Laterally, at the articular pole of the shoulder joint, lies the lateral angle. Here, on the neck, sits the glenoid cavity. The lateral border is thick and rises obliquely upward from the inferior angle toward the side. The medial border, closer to the spine, runs almost vertically and ends superiorly at the superior angle. Now let's turn to the posterior surface of the scapula. This is divided by the scapular spine into two regions. Above is the supraspinous fossa, and below is the infraspinous fossa. Next, let's look at the superior border of the scapula. On its medial part there is a deep notch, the scapular notch. Lateral to this arises the coracoid process. Finally, the superior angle is located here, the upper endpoint of the medial border. On the edge of the acromion there is a characteristic point, the angulus acromii, the angle of the acromion. On the medial, anterior surface of the acromion we can see the facies articularis clavicularis, the articular surface for the clavicle. If we turn the scapula laterally, we can see the cavitas glenoidalis, the glenoid cavity. This articulates with the caput humeri, the head of the humerus, forming the articulatio humeri, the shoulder joint. The cavitas glenoidalis itself is a shallow, pear-shaped depression with a narrowing apex superiorly. Beneath the cavity lies the tuberculum infraglenoidale, the infraglenoid tubercle, from which certain muscles originate. On the posterior surface, below the spine, extends the fossa infraspinata, the infraspinous fossa. Running across the center is the spina scapulae, the scapular spine. It begins medially from a triangular base, gradually rises into a prominent crest laterally, and then continues into the acromion. Between the spine and the cavity there is a small passage, the incisura spinoglenoidalis, the spinoglenard notch. On the anterior side again, we see the fossa subscapularis, the broad anterior depression. Above the cavity there is a small but important structure, the tuberculum supraglenoidale, the supraglenoid tubercle. Finally, the area above the spine is the fossa supraspinata, the supraspinous fossa. To summarize, the scapula is triangular, its medial border is nearly vertical, the inferior angle points downward, and the bone lies over the 2nd to 7th ribs. The spina scapulae divides the posterior surface and continues into the acromion. Above and below the cavitas glenoidalis lie the tuberculum supraglenoidale and tuberculum infraglenoidale. On the superior border, the incisura scapulae is an important landmark. With this, you can confidently identify all the essential features of the scapula on the model. In this section we will go through the humerus. We start with the proximal structures, then proceed along the shaft to the distal end. The first landmark is the column anatomicum humeri. This is a shallow, circular groove that separates the cartilage-covered head from the two tubercles. Here the surface covered with hyaline cartilage ends, and from this point begin the attachment zones for the shoulder muscles. Next is the corpus humeri, the shaft of the bone. In its upper part it is more cylindrical, while further down it takes on a rounded triangular cross-section. Along this region run the ridges and rough surfaces that provide muscle attachment and distribute the pulling forces during movements of the arm. Continuing downward we reach the condylus humeri, the distal articular block. It carries the articular surfaces that belong to the elbow joint. Later we will highlight the capitulum and the trochlea, as well as the surrounding fossae. On the proximal end, laterally, rises the tuberculum majus. It is a broad, polygonal area for muscle attachment, where several of the rotator cuff muscles anchor. From here runs its own crest downward, leading toward the anterior surface of the upper arm. On the anterior surface, more medially, lies the tuberculum minus. It is smaller than the greater tubercle, but its muscle attachment is essential for internal rotation of the shoulder. The connection between the two tubercles is shown by the longitudinal groove. Finally, let's look at the head of the humerus, the caput humeri. The head faces medially, upward, and slightly backward. Its spherical surface fits precisely into the glenoid cavity of the scapula, allowing a wide range of motion in the shoulder joint. Now we come to the longitudinal borders and surfaces. The anterior edge is the margo anterior humeri. From here the proximal crests run downward, and this border gives the anterior contour of the arm. The anterolateral surface, the facies anterolateralis humeri, approaches the attachment zone of the deltoid muscle. That is why this surface is slightly convex and built of stronger bone. Next to it is the anteromedial surface, the facies anteromedialis humeri. Here the bone is smoother, and the course of the proximal crests is clearly visible. The lateral border, the margo lateralis humeri, defines the outer contour of the arm. Toward the distal end it transmits the tension of muscle origins and ligaments toward the elbow. The distal outer projection is the epicondylus lateralis humeri. This is the main origin for the forearm extensor muscles. Just above it, running upward, is the crista supracondylaris lateralis, a sharp ridge that can easily be followed by palpation. The inner longitudinal border is the margo medialis humeri. At its distal end lies the larger projection, the epicondylus medialis humeri. This serves as the principal origin for the flexor muscles, and therefore forms a more prominent elevation. From here the crista supracondylaris medialis runs upward, forming a ridge on the inner side of the arm and guiding the eye from the elbow back toward the trunk. The large posterior surface is called the facies posterior humeri. On this surface appears the characteristic groove marking the course of the nervus radialis. Now let's move on to the distal articular surfaces. Laterally lies the capitulum humeri, a rounded surface that slopes slightly forward. It articulates with the head of the radius and allows rolling movement on the outer side of the elbow. The other half of the distal articular block is the trochlea humeri. This is an elongated, spool-shaped surface with an axis slanting slightly medially. It articulates with the notch of the ulna and guides flexion and extension of the elbow. In front of the trochlea, medially, there is a shallow depression, the fossa coronoidea. Into this fits the coronoid process of the ulna during elbow flexion, preventing bony collision at the end of the movement. Anteriorly, laterally above the capitulum, we find the fossa radialis. During flexion, the head of the radius sits here, ensuring smooth movement. On the posterior side, at the center of the distal end, is the deep fossa olecrani. During extension, the olecranon of the ulna fits precisely into this hollow, stabilizing the end position of the movement. On the distal medial side there is a deep groove behind and below the epicondylus medialis, the sulcus nervi ulnaris. The ulnar nerve passes here, which explains the characteristic electric shock sensation when the elbow is struck. On the posterior surface, running from medial to lateral in a spiral direction, is the sulcus nervi radialis. In this groove course the radial nerve and its accompanying vessels, producing the characteristic groove of the posterior arm. On the outer middle third of the shaft there is a broad rough surface, the tuberositus deltoidea. Here attaches the deltoid muscle, the main mover in raising and swinging the arm forward and backward. At the junction of the proximal end and the shaft lies the column chirurgicum humeri, the surgical neck. This is a mechanically weaker zone, and fractures of the upper limb often occur here when falling on the arm. From the greater tubercle descends the crista tuberculi majoris. In parallel, on the medial side, runs the crista tuberculi minoris. Between the two crests on the anterior surface lies the sulcus intertubercularis. The tendon of the long head of the biceps passes through this groove, covered by a strong ligamentous roof forming a canal. To summarize, it is worth constructing a mental map. Proximally, the head, the anatomical neck, and the two tubercles form the shoulder pole. On the shaft, the two crests, the deltoid tuberosity, and posteriorly the radial groove are the most important landmarks. The condylus with its two parts, the capitulum and the trochlea, together with the epicondyles and the three fossae, define the topography of the elbow. This gives the complete picture of the humerus structures on the model. Now that we have reviewed the humerus and its important bony landmarks, it is worth mentioning a common condition directly related to these attachment sites, epicondylitis humeri, the collective name for tennis elbow and golfer's elbow. The essence of epicondylitis humeri is that the tendinous origin of the forearm muscles at the outer or inner epicondyle undergoes chronic overuse. Repetitive movements lead to microtrauma and degeneration in the tendon. Importantly, this is not a classical, acute inflammation but rather a tendinopathy. Symptoms therefore develop slowly and insidiously, and they are load-dependent. Two main forms are distinguished. Lateral epicondylitis, better known as tennis elbow, involves the origin of the extensor muscle group at the lateral epicondyle. The short wrist extensors are often the main source of pain. The other is medial epicondylitis, or golfer's elbow, where the flexors and the pronator teres arise from the medial epicondyle. The two forms behave like mirror images. The lateral one causes pain on the outer side, the medial one on the inner side. The symptoms are characteristic. There is tenderness on palpation over the affected epicondyle. Pain appears on exertion and with specific movements, often radiating into the forearm. In everyday life, this is noticed when opening a bottle, turning a key, scrolling with a mouse, or hammering. A sudden stabbing pain shoots in. Grip strength decreases, and patients may drop objects because the pain prevents them from holding firmly. Diagnosis is primarily clinical. In Cousin's test, the patient extends the wrist against resistance with the elbow extended and forearm pronated. In lateral epicondylitis, this provokes immediate pain. Mill's test is passive stretching. With the elbow extended and forearm pronated, the wrist and fingers are maximally flexed. This also provokes lateral pain. The flexion, pronation test points to the medial form. The patient flexes the wrist and pronates the forearm against resistance, causing pain on the medial side. Imaging is rarely required, mainly if the presentation is atypical or symptoms persist. First-line treatment is conservative. Rest and activity modification, a short course of non-steroidal anti-inflammatory drugs, and targeted physiotherapy are key. Stretching and gradual strengthening, especially eccentric exercises, are emphasized. Correction of workplace ergonomics and sports technique is often decisive. If symptoms persist, injection therapy may be considered, short-acting corticosteroids or platelet-rich plasma. Surgery is rarely indicated, only if conservative measures over several months bring no improvement. The key point: this is an overuse-induced tendon origin injury, with characteristic provoking maneuvers and well-targeted physical tests. With consistent load reduction and guided exercise therapy, most cases heal well. Let's turn to the radius. We begin with the shaft, the corpus radii. This is a slender bone. Proximally it is more cylindrical, while further down it takes on a triangular cross-section. Of the two forearm bones, it is the more mobile one, shorter than the ulna. It starts slightly lower proximally, but at the wrist it reaches a little farther. All directional terms are understood in the standard position, with the palm facing forward. Moving down to the distal part, the pars distalis radii broadens considerably. On the dorsal side it is gently convex, and longitudinal grooves can be seen for the extensor tendons, the sulci tendinae. In the center there is a small puller-like elevation, the tuberculum dorsale, which guides the extensor tendons as they change direction. On the lateral edge, toward the thumb side, projects a strong process, the processus styloideus radii. On the medial side there is a crescent-shaped notch, the incisura ulnaris, which receives the head of the ulna. The entire distal articular surface for the wrist is the facies articularis carpi, an oval, shallowly concave surface that articulates with the carpal bones. At the proximal end we find the head, the caput radii, a small disc-shaped structure covered with cartilage. On its top lies the fovea capitis, which articulates with the capitulum of the humerus. Around the margin runs the smooth, circular surface of the circumferentia articularis, which articulates with the radial notch of the ulna and allows pronation and supination. Beneath the head is the slender column radii, the neck of the bone. On the anteromedial surface below it is a rounded roughness, the tuberositus radii, where the tendon of the biceps muscle attaches. Now let's review the longitudinal borders and surfaces of the radius. The anterior edge is the margo anterior radii, which defines the anterior contour of the shaft. Next to it lies the anterior surface, the facies anterior radii, a smoother, slightly concave area where the anterior forearm muscles run and attach. The intermediate, medial edge is the margo interosseous radii. This is the sharpest border, since the interosseous membrane, the membrana interossea, is anchored here between the two forearm bones. The lateral surface, the facies lateralis radii, is more convex. It is broader proximally, and then narrows as it approaches the styloid process. The posterior edge, the margo posterior radii, is less sharp but leads directly to the dorsal grooves. The posterior surface, the facies posterior radii, is convex. Here lie the sulci tendinae, which divide the extensor tendons of the hand into separate tracts. The tuberculum dorsale gives them a guiding change in direction. A special point to highlight is the articular surface toward the scaphoid, the facies articularis scaphoidea radii. This is the larger, lateral compartment of the distal articular surface, which contacts the os scaphoideum and transmits most of the load to the wrist. In contrast, on the medial side we find the incisura ulnaris, the notch for the head of the ulna. This forms part of the distal radio-ulnar joint, which together with the proximal connection allows the rolling, gliding movement of forearm rotation. Now let's continue with the detailed features of the radius. At the top of the radius we see the caput radii. This is a disc-like head covered with cartilage, which provides rolling, gliding movement from the elbow side. In the center of the head lies the depressed socket, the fovea articularis capitis radii. This articulates with the capitulum of the humerus and bears the load at the elbow joint. The margin of the head is encircled by a smooth cylindrical surface, the circumferentia articularis capitis radii. This connects with the radial notch of the ulna and with the annular ligament, the ligamentum annulaire, keeping the head in place while allowing it to rotate freely during pronation and supination. Beneath the head comes the slender constriction, the column radii, which links the head to the shaft. On the anteromedial surface, immediately below, rises a mound-like roughness, the tuberositus radii. Here the tendon of the biceps muscle attaches, transmitting flexion force into the bone. From here we move down toward the shaft, then reach the distal region. On the dorsal side rises the tuberculum dorsale radii, a small but important guiding pulley where the tendon of the extensor pollicis longus changes direction. Alongside it run longitudinal channels, the sulci tendinum extensorum. These arrange the dorsal hand tendons into separate tracts, so the dorsal surface of the radius functions like an organized system of grooves. On the lateral edge, toward the thumb, stands a strong projection, the processus styloideus radii. This is a palpable landmark on the outer side of the wrist and serves as an anchoring point for the ligament system. The distal articular surface facing the wrist is the facies articularis carpi, divided into two characteristic compartments. Medially lies the facies articularis lunata radii, which articulates with the lunate bone, the os lunatum, and transmits a significant share of load. Laterally, the facies articularis scaphoidea radii joins the os scaphoideum, transmitting most of the load into the carpus. On the distal medial side is a crescent-shaped notch, the incisura ulnaris. Here the head of the ulna fits. This surface works together with the proximal connection to provide the rolling, gliding rotation of the forearm. To summarize, proximally, the head with its fovea and circumferential articular surface form the connection at the elbow. Below them, the neck and the tuberositus mark the biceps attachment. Distally, on the dorsal side, the tuberculum dorsale and the longitudinal tendon grooves guide the extensors. On the lateral side, the processus styloideus provides a landmark. At the wrist, distinct articular surfaces for the lunate and the scaphoid transmit load, while medially the incisura ulnaris receives the ulnar head. This completes the chain of anatomical landmarks of the radius from proximal to distal. In the following, we will look at one of the key bones of the forearm, the ulna, which plays a decisive role not only in the stability of the elbow joint but also in enabling the fine movements of the hand. First, let's consider the shaft, the corpus ulni. This is a slender bone shaft that gradually tapers downward. Its cross-section is triangular, which means it has 3 longitudinal borders, and the surfaces are aligned to these borders. Because of this, the bone can be well oriented even when held in the hand. If we move further down, we reach the pars distalis ulni. This is a small but cartilage-covered articular end. Here lies the small head, which forms the distal radio-ulnar joint together with the radius, and from here arises the needle-like styloid process. Despite its small size, this part provides important surface landmarks at the wrist. Now let's return to the pars proximalis ulni, the massive upper end at the elbow. Its characteristic wrench-like shape is formed by the large trochlear notch, which is bounded posteriorly by the huge olecranon and anteriorly by the smaller, forward-projecting coronoid process. Next, let's go through the borders and surfaces of the ulna in order. The anterior edge, the margo anterior ulni, forms the anterior contour of the shaft. Next to it lies the anterior surface, the facies anterior ulni. This area is mostly smooth, and the anterior forearm muscles rest upon it. The sharpest border is the margo interosseous ulni, where the interosseous membrane between the 2 forearm bones is attached. This is an excellent landmark that can be followed along the entire length of the bone. On the inner side runs the facies medialis ulni, while posteriorly we find the margo posterior ulni, a ridge that can be palpated clearly along the whole forearm. The large continuous posterior area is the facies posterior ulni. Here the tendons of the posterior muscle compartment lie, and some of the extensor muscles also take their origin from this surface. Proximally, on the lateral surface, runs a sharp ridge over a shorter distance, the cristus supinatoris. This provides the strong attachment site for the supinator muscle. Now let us examine the structures of the ulna in detail, moving from the elbow region distally. At the very top we find the prominent olecranon, a hook-like projection that fits into the posterior fossa of the humerus during extension. The tendon of the triceps attaches here, making this the main lever for elbow extension. In front of it opens the incisura trochlearis, the cartilage-covered trochlear notch. Along its midline runs a longitudinal guiding ridge with a subtle twist. This matches the corresponding groove of the trochlea of the humerus, and like a rail it prevents axial slipping, ensuring a pure hinge movement. The lower lip of the notch is the processus coronoideus. During flexion it fits into the anterior fossa of the humerus. In this way it braces the joint in front. The joint capsule also partly attaches here, which makes its stabilizing role especially important. On the medial margin of the processus coronoideus lies a small but crucial projection, the tuberculum sublime. The anterior bundle of the ulnar collateral ligament attaches here, making this the key point for valgus stability of the elbow. On the lateral side of the trochlear notch there appears a crescent-shaped articular surface, the incisura radialis. Here the head of the radius joins at the proximal radio-ulnar joint. This connection allows the radial head to roll and glide smoothly during pronation and supination. On the same lateral surface there is also a deeper muscular depression, the fossa supinatoria. This houses the supinator muscle, which turns the palm upward, making this part of the proximal ulna the engine cover of forearm rotation. Slightly further down, on the anterior surface of the proximal third, lies a large rough area, the tuberositus ulni. Here the tendon of the brachialis muscle attaches, transmitting the force of elbow flexion into the ulna. Moving down along the shaft, we eventually reach the distal pole. Here appears a small, rounded articular end, the caput ulni. Around its side runs a smooth cylindrical arc, the circumferentia articularis capitis ulni, along which the head rolls in the distal notch of the radius during forearm rotation. On the inferior surface of the head lies an additional articular area, the facies articularis capitis ulnae. This contacts the articular disc of the wrist and ensures smooth, painless movement on the ulnar side of the wrist. The lowermost point is the processus styloideus ulnae, a slender spike on the inner side of the wrist. It serves as an important ligament attachment and is an easily palpable landmark in everyday clinical examination. To summarize, the olecranon, the incisura trochlearis, and the processus coronoideus provide the locking and guiding mechanism of the elbow. The tuberculum sublime and the incisura radialis secure medial stability and the pivot for forearm rotation. The fossa supinatoria and the tuberositis ulnae serve as key muscle attachment sites, and distally, the caput ulnae with its circumferential and inferior articular surfaces, together with the styloid process, ensure the fine mechanics of the wrist. In this way, all the essential structures of the ulna can be clearly understood in sequence from proximal to distal. In this section we will review the major groups of the bones of the hand, so that you have a clear map before zooming into the details. All orientations are given in the standard position. The palm facing forward, the thumb side is radial, the little finger side is ulnar, the palmar side is the front of the hand, and the dorsal side is the back. The skeleton of the hand is divided into three major groups. The first is the carpus, or wrist. Here 8 short bones are arranged in 2 rows, a proximal row and a distal row. Together they form an arch, and on the palmar side this arch does not close completely. This creates the palmar groove of the wrist, the sulcus carpi. Its special significance lies in the fact that above it stretches the strong ligament of the flexor tendons, the retinaculum flexorum. Together, these form the carpal tunnel, through which the flexor tendons and the median nerve pass. We will briefly return to this at the end of the video. The second unit is the metacarpus, or palm. Here we count 5 long bones from radial to ulnar side, numbered 1 to 5. Each bone has a base, a shaft, and a head. The bases articulate with the carpal bones, while the heads form ball and socket joints with the proximal phalanges. These tubular bones create the longitudinal arches of the palm and transmit much of the gripping force. The third unit is the phalanges, or finger bones. The thumb has 2 phalanges, a proximal and a distal, while the other fingers have 3 each, proximal, middle, and distal. Each phalanx has a base, a shaft, and a head. The distal phalanges have a strong, bulbous tip beneath the nail, designed to bear loads during touch and fine grasping. Around the base joint of the thumb, sesamoid bones are usually present. These give the tendons a favorable leverage. In summary, seen from above, the 2 rows of the carpus form a palmar groove, the sulcus carpi, which is the basis of the carpal tunnel. In front of this, the 5 rays of the metacarpus connect the wrist to the bases of the fingers. Distally, the phalanges build the fingers, with the thumb having 2 and the other fingers 3 each. With this outline it becomes easy to place the detailed structures and understand how the arched skeleton of the carpus, the radiating force-transmitting metacarpus, and the fine mechanics of the fingers all work together. Let's begin with the carpus, or wrist. This is a unit made up of 8 small, cube-like bones arranged in 2 rows. The structure is both rigid and mobile. The bones do not lie in a single plane but instead form a concave arch on the palmar side and a convex arch on the dorsal side. This palmar concavity creates the base of the sulcus carpi, which we will discuss separately. In the proximal row, moving from the thumb side toward the little finger, we find the following bones: the os scaphoideum, the os lunatum, the os triquetrum, and finally the os pisiform. It is important to note that the pisiform does not stand in line with the others but rather sits on the palmar surface of the triquetrum, like a small seated bone, and therefore behaves differently in movement. In the distal row, from lateral to medial, we have the os trapezium, the os trapezoideum, the os capitatum, and the os hamatum. Among these, the os hamatum deserves special attention because on its palmar side it bears a palpable little hook, the hamulus ossis hamati. This hook, together with the pisiform, forms the medial boundary of the sulcus carpi, while laterally the tubercles of the scaphoid and trapezium mark the groove. In summary, it is useful to fix the scheme in mind like this: 8 bones in 2 rows. The proximal row is scaphoid, lunate, triquetrum, with the pisiform sitting on top. The distal row is trapezium, trapezoidium, capitatum, hamartum. The concave palmar arch forms the sulcus carpi, bounded medially by the pisiform and the hamulus, and laterally by the scaphoid and trapezium tubercles. Now let's look at the sulcus carpi, the palmar groove of the wrist. When the hand is held with the palm facing upward, the carpal bones form a concave arch. Its base is the bony floor, and its 2 sides rise as the radial and ulnar eminences. On the radial side, the proximal landmark is the tuberculum ossis scaphoidae and the distal landmark is the tuberculum ossis trapezii. Together, they form the outer boundary of the groove. On the ulnar side, the proximal point is the os pisiform and the distal point is the hamulus ossis hamarti. These two form the inner boundary. Between these 4 easily palpable bony landmarks stretches the groove itself, the sulcus carpi. It is important to remember that the carpal bones are arranged in 2 rows and not in a single plane. Because of this, their natural concavity toward the palm automatically creates the groove. When a strong fibrous roof, the retinaculum flexorum, spans between the 2 eminences, the open groove becomes a closed tunnel, the canalis carpi. Within this tunnel run the long flexor tendons and the median nerve, which is why these bony, ligamentous borders are of such great anatomical and clinical significance. To put it all together, laterally, the tubercles of the scaphoid and trapezium, medially, the pisiform and the hook of the hamate outline the 2 side walls. Between them, the arched carpal bones form the floor. It is worth fixing this picture in mind: 4 bony landmarks, 2 eminences, a bony groove, which with the spanning of the retinaculum becomes the canalis carpi. Now let's turn to the metacarpus, or palm. It consists of 5 short tubular bones, numbered from the thumb side toward the little finger as 1st, 2nd, 3rd, 4th, and 5th. Each bone has 3 main parts: proximally the base, in the middle the shaft, and distally the head. The shaft is slightly curved, with a gentle convexity toward the dorsum of the hand. Seen from the side, this curve creates the longitudinal arch of the palm and helps to distribute loads during gripping. The base is wedge-shaped and usually carved with flat articular surfaces, connecting both with the carpal bones and with neighboring metacarpals. Because of these small intermetacarpal facets, the palm's bony rays are both stable and flexible. The distal head is hemispherical, but its sides are cut off by palmar expansions, so the head appears wedge-shaped when viewed from the front. This form ensures smooth flexion and extension at the metacarpophalangeal joints, while guiding side-to-side movements with precision. A key landmark is that the palmar side of the heads is broader. The first metacarpal, the thumb ray, deserves special attention. Its base bears a true saddle surface with 2 perpendicular concavities. This articulates with the trapezium and provides the thumb with its exceptional mobility, abduction and adduction, flexion and extension, and the combined movement of opposition. The head of the first metacarpal is not hemispherical but rather cylindrical, resembling a trochlea. For this reason, the movement pattern at the thumb's base joint is different from that of the other fingers. In fact, in form it is closer to a phalanx. Now let's review the bones of the fingers, the phalanges. The fingers are numbered from radial to ulnar. The thumb is digitus primus, or pollex. Then comes the index finger, digitus secundus, or index. Next the middle finger, digitus tertius, or digitus medius. Then the ring finger, digitus quartus, or digitus annularis. And finally the little finger, digitus quintus, or digitus minimus. The framework of each finger is built of phalanges. Except for the thumb, each finger has 3, proximal, middle, and distal. The thumb lacks the middle phalanx and has only a proximal and a distal. Each phalanx is a short tubular bone with a proximal base, a shaft, and a distal head. The exception is the distal phalanx. Instead of a rounded head, it ends with a broad, rough tuberosity on its palmar side, the tuberositus phalanges distalis. This tuberosity anchors the connective tissue septa of the fingertip and provides firm support for the pulp of the finger and the nail, which is why we can palpate stably with a padded fingertip. To summarize, the thumb has 2 phalanges, proximal and distal, with a marked tuberosity at the distal end to support the nail and fingertip. The other fingers have 3 phalanges each, all with the base, shaft, head arrangement. The proximal base receives the rounded head of the metacarpal, creating a more mobile metacarpophalangeal joint. The middle and distal phalanges articulate in a cylinder and groove system, ensuring the precise hinge-like flexion and extension of the finger. Together, these structures provide the fine mechanics of the fingers, upon which all gripping and precise manipulation depend.